Good evening, all. Uh, so maybe in another 15-20 minutes, we'll go through important aspects of PKPD, like consideration in critically ill patients. So when it comes to critically ill patients, like adjusting the dosage, giving a bolus, and considering changes in the maintenance dosage and all. So basically, our thought process revolve around like renal dysfunction. That is the one area. Means liver dysfunction. Even though we have some concern, but we don't have much things to be done in terms of like consideration of the PKPD, because we have couple of antibiotics or maybe any sort of therapy, particularly sedative agents and all. So otherwise, our discussion when it comes to PKPD, so it roll around like critically ill patients with the background of kidney dysfunction. And other than that, one area, so we need to think like when a patient is on extracorporeal circulation. So when like not only on CRRT, SLED and all, so when patient is undergoing high volume plasma exchange. So next is like ECMO and all, okay. So the best way currently is like monitoring all these things is through the therapeutic drug monitoring. But current evidence is not supporting in terms of the cost effectiveness for all the antimicrobials what we use for TDM assessment and all. So we'll just try to understand some basics in and around this and the evidence for TDM, and we'll take a conclusion on this topic. See, why to adjust the dosage in any patient who is critically ill? So if you see, the data suggests many patients are underdosed when a routine one size fits all antibiotic dosage is being given with the background of acute kidney injury. So around 25 to 60% of patients receiving continuous renal replacement therapy have subtherapeutic antibiotic levels. So there are lots of pros and cons at the bedside. We'll discuss. Okay, lots of arguments will happen how to like dose when patient is on CRRT and all. So that finally end up so significant subtherapeutic like dosage. So obviously when we have a subtherapeutic dosage, so efficacy will be compromised and it will add to the origin of more and more drug resistant organisms and all. So the dosage regimen, so what we do at the bedside, so we have some aims to achieve two objectives: to reach the same maximum and minimum blood level, to achieve similar amount of drug in the body during a given dosage interval for both normal and renal failure patients. So this is what we really want. Means whether a patient is having a renal dysfunction or with a normal renal function, same concentration of antibiotic or any other therapy which we are going to give should be achieved in both the patients. Okay. So just for understanding, we know that there is something called pharmacokinetics. So this is the movement of whatever the therapy, whatever the pharmacological intervention we do, so till it reaches its effect site concentration. Okay. So it mixes with the biological fluid. So that we call it as a pharmacokinetics. For pharmacodynamics is something like the final ultimate what is going to happen. So we given an antibiotic, what is going to happen at the level of the receptors in the final action, that we call it as a pharmacodynamics. Okay. So if you see PKPD, it's going to depend upon many factors in an ICU patient. So drug solubility itself means whether we are giving a water soluble agent or lipid soluble agent. It is very, very important. See, most of the commonly used antibiotics are water soluble. Okay, so aminoglycosides, beta lactams and all. So volume of distribution, this is the apparent volume into which a particular antibiotic or a drug which is got distributed. So normally volume of distribution is equivalent to in a like water soluble agent, that's almost similar to that of the plasma volume, intravascular compartment. So clearance, this is the amount of the drug so cleared per unit time from that of the body. That is what we call it as a clearance. So clearance depends upon cardiac output. Good cardiac output, good blood supply to kidney and liver, so adequate clearance. Okay. So it depends upon protein binding. So less protein binding, so they are going to cleared rapidly. End organ function. So liver dysfunction, kidney dysfunction, obviously we are not able to clear the drug adequately. So they are on plasma exchange. So renal replacement therapy, like extracorporeal membrane oxygenation and all, so it's going to have an impact in terms of the clearance, because there is an increase in like volume of distribution again. So the membrane like characteristics, all these things play. So when it comes to clearance, then we have a half life. Okay, so this is the time required for 50% reduction of the concentration. It depends upon the volume of distribution and that of the overall clearance. Okay, in critically ill patient, it's not straightforward. So each component will have an interlink. So we'll try to understand all these things. Okay. So when it comes to volume of distribution, so we know that patient is septic. So acute liver failure, burns, trauma, severe acute pancreatitis, immediate post-surgery, they are going to be hyperdynamic circulation, okay. So their volume of distribution is going to be increased. So hydrophilic remain in the central, that is the vascular compartment, tend to have a lower volume of distribution with a value that is closer to that of the intravascular volume. So this is in a normal scenario, because so the distribution of water soluble agent is going to happen in the intravascular compartment. When it comes to lipid soluble, so it is going to get distributed in the adipose tissue. So normally the take home here is volume of distribution of hydrophilic agent is bit less, and it is as equivalent to that of the like blood volume as compared to lipid soluble agent, that is going to be more. So that is take home one we need to remember. If you see the impact of critical illness on the solubility and volume of distribution. So remember, hydrophilic agent, so low volume of distribution, this is in a normal patient. So what is going to happen in a critical ill patient, particularly septic, because of the peripheral vasodilatation, because of the distributive nature of the shock, their volume of distribution is increased for hydrophilic agents. So increase or decrease in clearance, this depends upon the existing renal function. So whenever there is a increase in volume of distribution, so obviously if you are not going to match that with the additional bolus dosage for water soluble agent, so it is not adequate to reach at the tissue penetration and the tissue concentration and all. So that is the interlink between the solubility and volume of distribution in relation to that of the critical illness, okay. So I told most of the agents what we use, they are water soluble. Aminoglycosides, all our beta lactam agents, so including carbapenem, cephalosporins, penicillins and all. So linezolid, glycopeptide like vancomycin, teicoplanin. So colistin, daptomycin, that is a lipopeptide group of antibiotics. So when it comes to lipophilic, so in a critical illness also fairly overnight nothing will happen to the adipose tissue. So their distribution remains in and around the same, okay. So their interstitial penetration, tissue penetration is not going to get affected in a critical illness when we are choosing a lipid soluble agent, okay. So for example, you are giving quinolones, macrolides, okay, tetracycline, tigecycline, that is the glycycline, tetracycline. So nothing to worried about the distribution when it is a lipid soluble agent, okay. So again, impact of solubility and dosing. So renally cleared antibiotic agents, so hydrophilic agents. So there is something called, we need to give a, so front loading of all like hydrophilic agent in a critically ill patients, particularly glycopeptides, vancomycin. We need to give a very good first dosage to achieve that like impact which is created by that of the critical illness in terms of the volume of distribution. So then the question is, patients in the initial phase of sepsis or trauma or in the immediate phase of the burns or post surgery and all, so they will have something called augmented creatinine clearance, okay, particularly for water soluble agents. So if you take like colistin, so we know that colistin is available as a prodrug, colistomethate sodium. So it is has to get converted into active moiety, that is colistin. Suppose if you are not taken care of this augmented creatinine clearance, whatever the dosage you consider as a normal, so before it get converted into active moiety, that is colistin from colistomethate sodium, it's going to get excreted so exponentially through the kidneys. So that's why always remember, irrespective of the renal dysfunction, you need to take care of this augmented creatinine clearance when it comes to water soluble agents, okay. So other than this, so when we think about the clearance, so first thing which comes into our mind is renal clearance. We have a non-renal clearance for certain drugs, like drugs may get excreted in motion. So sweat, even though it is a negligible like quantity, but we are not considering all those things. But you have to remember, so when it comes to clearance of an agent, so it is the renal clearance with that of the non-renal clearance. But the problem is we are not able to measure this non-renal clearance so on a routine basis. Do you think it is so easy to adjust the antibiotic dosage considering solubility, volume of distribution, so clearance, renal versus that of the non-renal clearance? Obviously, it is not a so easy task when it comes to adjusting the dosage. Again, sepsis, its impact initially they can have a high output. So when we have an increased cardiac output, so there is an increased clearance because of adequate blood supply to that of the end organs and all. So when they have a leaky capillaries, altered protein bindings, so there is an increased volume of distribution. So apparent the concentration in the plasma may be very low. So, or they might be having a adequate functioning organ, so then we are able to achieve the normal plasma concentration. Are they present late? You are a tertiary care or a quaternary care center, so they might be already having a renal dysfunction established. So then whatever the dosage you give, so that appears to be heavy for that particular patient. But the problem is sepsis or any critical illness is a dynamic process. Okay, so it's very difficult to define, okay, my patient is in this category, so on any particular time, because in the next hour itself their renal dysfunction may worsen. So very difficult, even if you understand all this concept, to means adjust the dosage at the bedside. Okay, so other than this, we have a innate characteristics of the antibiotics or the any other agents itself. So one, like we have the interaction between volume of distribution, clearance, solubility, so impact of critical illness. The drug itself is having its own characteristics. So that also we need to consideration. So when it comes to adjusting the dosage and all. So we have some antibiotic which work by concentration dependent principle, for which we need to give a very good high initial dosage, particularly amikacin. Okay, so we need to give up to 20 to 25 milligram per kg irrespective of renal dysfunction as a first dosage. So amikacin, which works by concentration dependent, we are going to come down in terms of like its frequency, means we are going to increase the frequency, but we are not going to compromise on the dosage. We keep same 20 milligram per kg. Okay, very good concentration we are going to achieve if you give a very good dosage of the aminoglycosides, but we are going to increase the frequency if at all required to adjust the dosage and all. Then we have a time dependent. See, almost all beta lactams work by time dependent killing, means in between that interval, 8th hourly or 12th hourly interval, so we need to maintain the antibiotic concentration above the level of minimal in vitro concentration by at least for 40% of that interval time. So means you are giving 8th hourly meropenem, means at least the meropenem concentration should be above MIC for at least 3 to 3.5 hours. So that comes only if you are giving it as an infusion. So ideally, so carbapenems or a beta-lactam should be given as a 24-hour infusion. But the problem is, once you make reconstitution, the stability of the molecule is not going to be sustained. So then what we do? Extended infusion. So one, we have a mixed masala of all these things, volume of distribution, clearance, solubility and all. To confuse that, again, the property of particular antibiotic we need to understand when we adjust the dosage. So it's not so easy at the bedside. So it is not so straightforward. So this is the PKPD indices of all the antibiotics, okay, which work by, so AUC under MIC are concentration dependent or time dependent. So that is very essential for the trainees to remember. Very, very important. Okay, it's not so easy just like giving a meropenem. So over 1 hour, if it is a maintenance dose, it's not going to adequately achieve and it's not going to have a adequate efficacy. You need to understand this PKPD principle also. Again, one more problem is which concentration to follow. So to confuse more, we have MIC, okay, breakpoint concentration, mutation prevention concentration and all. We know that even though we get on the paper something called MIC, so it's not straightforward to choose any particular agent and to adjust the dosage based on the MIC. Okay, so there is something called susceptibility dose dependent. So other than that, SDD means, so some antibiotic we got on the paper as an intermediate sensitive, but if you give a adequate dosage, very good dosage, an intermediate can be converted into susceptible. Okay, that we call it as SDD. But other than that, so based on MIC, it's very difficult to decide dosage or the selection, because MIC gives a static measure. Okay, you send the culture sensitivity today. So what happened when we got the report? So it is a dynamic process. That's why it is a static. It's not a dynamic indices. So it measures only growth inhibition, not killing capacity of that particular antibiotic. Again, MIC will not taken into consideration of this post antibiotic effect and all. So then, so it's not so easy to understand PKPD just based on all these concepts. So it is beyond that. Okay. So which drugs we need to adjust? Suppose we understand all the PKPD profile and all. For those with a predominant renal clearance, meropenem, which is having a 70% renal clearance, we need to adjust whenever needed. See, meropenem per se is not nephrotoxic. We adjust the dosage because it is renally cleared. It's not nephrotoxic like colistin or aminoglycoside. Okay. So for those with the altered volume of distribution, particularly I told water soluble agents, there is a big impact of the solubility in relation with that of the volume of distribution. So that need to be adjusted. For those with the increased risk of side effect, so which are having a marginal, like narrow margin of the safety and all, colistin, okay, so that we need to take care. or for those with a narrow safety margin, stringent monitoring is needed like that of the digoxin and all. So next comes the concept of, can we calculate the dosage of the antibiotic just based on something called Cockcroft-Gault formula and all. So we have multiple things, okay, calculating GFR by Cockcroft-Gault formula. So there is an MDRD formula. So then we have some radioisotope technology and all. It is beyond the scope on a routine basis at the bedside. So we assume, so anuric patient is having a GFR less than 10. So is it so easy for assumption? So I'll tell it is not so easy, okay. So on dialysis, so we take GFR as 15 and we calculate the dosage of the antibiotic. Again, it is not a correct way to calculate. First, if you consider like understanding creatinine clearance and thinking adjusting the dosage based on the creatinine clearance, it is based on many assumptions, okay. We need to understand, so a drug's renal clearance is proportional to creatinine clearance. This is the first assumption we are doing. So we are calculating creatinine clearance and we are assuming meropenem clearance is same as that of the creatinine clearance. That is the first assumption, that is wrong. So next, so non-renal clearance remain constant when renal function is impaired. So we are not considering the non-renal clearance. We are not measuring, okay, so it's excretion in the feces, in the sweat. So we are not considering that. Some antibiotic will have that impact when it comes to dosage calculation. So renal clearance of the drug declines in linear fashion with that of the creatinine clearance. This is the third assumption. That is not so, okay. So creatinine clearance and renal clearance may not match hand in hand, because so the creatinine value is going to rise in a lag way, okay. It is not a very live program. So patient will have a significant rise in creatinine by the time, so there is a much of irreversible kidney damage has been happened, okay. So there are lots of limitations for Cockcroft-Gault formula. So not all individuals generate the waste at the same rate. So if you give a too much of volume resuscitation, assume you given 3-4 liter in the initial period only, initial 24 hours, it will have a dilutional effect on the creatinine, okay. If patient is hemoconcentrated, so he can have a high creatinine. He is having a bulky muscle mass, he can have a high creatinine. So we can't rely on creatinine value and creatinine clearance for calculating our antibiotic dosage. So Cockcroft-Gault formula not valid for patients who are having a creatinine of more than 5. So serum creatinine always assess the kidney function in arrears. This is what I told, okay. So there is a lots of delay will be there. So in AKI, the volume of distribution changes rapidly, so that changes in plasma levels arise not just from the changes in the generation and clearance, but also from the change in the body water. So this is we are neglecting when you just stick on to creatinine clearance calculation and adjusting the dosage. So plasma creatinine concentration can vary with many other reasons which I mentioned already, okay. So overcoming this limitation, so really we need some sort of real-time creatinine clearance at the bedside. See, if you send creatinine today, so in most of our ICUs, at least it will take 4 to 6 hours. Where is the question? We get, okay, it's like ABG or a blood sugar monitoring. You check and you will get the value and you calculate creatinine clearance. It is very, very difficult, okay. So 4-hour creatinine clearance, there is some data available. They calculated creatinine clearance more frequently. They try to adjust the dosage. It is not practical. So basically the take home, it is not straightforward just to adjust the dosage based on creatinine clearance. So how to calculate loading dose? So we know that, so irrespective of the renal dysfunction, the first dosage, whether you are using a water soluble agent or a lipid soluble agent, should be given adequately as a full dosage, because there the impact of clearance is very minimal. The impact of volume of distribution is going to take over that of the impact of the clearance, because that will have a decision how much your concentration of antibiotic is going to be in the blood. So this is the concept of augmented creatinine clearance I told. So when a patient is having a acute illness in the initial days of sepsis or a burns or trauma, so they can have a creatinine clearance up to 300, okay, 250 and all. So in that case, water soluble agents, they can excrete it very fast. So you need to give a very good front loading for a particular water soluble agent and all. So when it comes to see, loading dose, it is very simple. So don't adjust anything for the creatinine, just give a full dosage. No confusion on that. When it comes to calculating the maintenance dosage, so greater than 50% renal excretion, definitely we need some adjustment for the maintenance dosage. So low rate of protein binding, small volume of distribution, all these things we need to take care. So in terms of adjusting the maintenance dosage and all. So one way of adjusting the dosage, you increase the frequency. Means you are giving meropenem 8 hourly, make it BD. Okay, so that is one way. Or you are giving aminoglycoside amikacin OD, make it once in 48 hours. So other way of adjusting is, okay, you are giving 1 gram meropenem. Instead of 1 gram, you come down to like 500 milligram kind of this one. So these are the two ways which we can adjust. So there are some like defined formulas. So dosing interval we can adjust by this formula. So normal creatinine clearance into normal interval divided by patient creatinine clearance. So that way we can adjust the dosing. So maintenance dosage, like you can decrease the dosage by using this formula, patient creatinine clearance into normal dosage divided by that of the normal creatinine clearance. But each one is having its own drawback. Okay, suppose if you adjust the dosage interval, so finally we are going to have a subtherapeutic trough level. We know that trough level is something which we measure just before the next dosage of the antibiotic. Trough level gives an idea about the post antibiotic effect, particularly for quinolone antibiotic and all. So that we are going to compromise if you are going to adjust the interval. Suppose if you reduce the dosage, so keep the same frequency, but we worried about the toxicity and there is a problem. See, if you compromise the dosage, first dosage itself or a maintenance dosage, then it may not have adequate potency and all. So that's why again it makes very confusing to adjust the dosage. It's not so easy even if you use all these formulas and all. To add on to confusion, we have RRT modality. We are giving SLED, HD, CRRT, type of membrane used, porosity size, efficacy of the dialysis membrane and all, dosage, effluent dosage and all. So many things to alter PKPD in a critically ill patient. It's not so easy. So some guidelines, some data is there. On a day of SLED, you can keep creatinine clearance as 60 and give a full dosage. Of the days of SLED, so you take a creatinine clearance of 10 ml. So accordingly you adjust the dosage. There are predefined tables available, so which you can go through. But in a sick patient, don't jump on adjusting when a patient is on SLED or IHD. Go ahead and give a full dosage. Don't bother, because at least for 48 hours, the patient is on 100% oxygen, 20 ml NARAD and all. So don't compromise the dosage for a couple of days, maybe at least 48 to 72 hours and all. So next, like one more impact you need to taken into consideration, their innate urine production. Say patient is having creatinine of 5, patient is a bit moderately stable, you calculated the dosage according to creatinine clearance, but is still having 15 ml per hour of the urine production, 10 ml per hour of the urine production. If it is 15 to 20 ml, so in 24 hours that become around 300 ml of urine production. That will add to the significant excretion of antibiotic. No need to stringently calculate creatinine clearance and adjust the dosage. So take home here is, again you need to give some value to the innate urine production. That don't neglect, just jump on seeing the creatinine. So this is one of the PKPD models. So if a patient is having residual urine production of around 300 ml, so that will add to the significant excretion of the meropenem. That you need to take into consideration. Okay. So again, like on CRRT, there is data available. Okay, you take 30 to 35 ml per minute. So these are some of the ready tables available for calculation of the antibiotics. But again, the take home, so individualize the dosage. Doesn't like look for the table and jump on calculating from day one only. So this is just for example. Okay, cholesterol dosage. So remember, we need to give at least 30% of extra dosage post SLED or post intermittent hemodialysis. On CRRT, go ahead and give a full dosage and all. So when to increase or decrease, this is to summarize. So I told like all these water soluble agents. So in a initial stage, give a full dosage. When a sick patient, so just individualize the dosage. Don't jump on adjusting the dosage and all. So lastly, is there any evidence? Is there any answer for all this confusion in critically ill patient? How to adjust the PKPD and all? Is the answer from therapeutic drug monitoring? These are some of the data long back. Okay, in terms of beta-lactam group of antibiotics, if you consider TDM for all the antibiotics, it is not cost effective. We are not yet reached that level. We do TDM for glycopeptides, aminoglycosides. We do TDM for voriconazole, posaconazole and all. That is acceptable considering their varied PKPD profile. That is like individualized like variation will be there. But to apply the entire thing, this is one of the systematic review and like TDM monitoring. So particularly we are not in that position because we need some monitoring, okay, which is like an ABG machine or a glucometer to tell the TDM on a live basis. It's not you send the TDM to Mumbai and you will get after 72 hours. It doesn't mean it's not going to serve the purpose and all. Even survival sepsis guidelines, they are more suggesting towards TDM wherever applicable, but that should be available on the floor, at least in the city or maybe in the institute. Otherwise, it doesn't mean if it is taking more than 24-48 hours and all. So take home message, individualized dose regimen, okay, so depending upon the sickness of the patient. So front loading is the best option for water soluble agent. So hydrophilic agents don't bother about the initial dosage. So impact of volume of distribution you need to taken into consideration, should be adjusted continuously. Remember, today's creatinine is 3, maybe tomorrow it is 1.5. Don't think today you made 500 milligram ethyl meropenem that you run for 1 week and all. So you need to understand the dynamicity of the patient also. So therapeutic drug monitoring should be subsequently give some answer to all these confusion and all. Thank you.